why the duodenal switch surgery is more riskier or more complicated than a gastric sleeve or the Roux-en-Y? Well, basically, what we're doing with a gastric sleeve, it's basically just a restrictive procedure. We're removing all the basals from the stomach, stapling, cutting the stomach, we're leaving the pylorus. With a gastric bypass, we're cutting the stomach and creating a little pouch, and then we're rerouting the intestine. There's some part of the body that is very delicate, and that's the duodenum. That's the first portion of intestine that it comes with a lot of basals, a lot of blood supply. There's a lot of tissues around, and it's a very, very small working space. So just to remove scarring tissue or just to clean everything so we can staple the duodenal stump requires a lot of work and requires a lot of patience and dedication to avoid any damage to other structures. What other structures? Well, there's a lot of basals, gastric basals, duodenal basals. There's some tissues. For example, the gallbladder is very, very close. Bile ducts are very, very close. Pancreatic ducts and all the tissue, the pancreas is very close. So we need to be very careful to get all the blood supply. What happens when you're stapling very close when the pancreas drips the liquid and the bile drips the liquid and the second portion of the intestine? Well, the risk is that we can cut if we don't separate and dissect all the tissues. We can cut either too far and we can cut that bile. So the bile supply is very important for the intestinal metabolism. So what we do is basically remove or dissect all the scarring tissue. And then we measure and cut, and we make sure that the blood supply to the duodenal stump it's full. So that means that the patient will have enough blood supply to create a neoanastomosis, and it will be not any complication on this section. Then we need to measure the full intestine. Sounds very easy, but laparoscopic on a high BMI patient is not that simple. We need to measure the intestine, move position, and then after we measure the full intestine, the full length of intestine, we do the anastomosis. We open all the space, the mesenteric space, so we can get the limbs up. But as we have fat on the outer sides of our body, inner we have fat as well, and that fat is heavy. So the intestines will be just basically having that weight of the fat. So the anastomosis need to be very loose. So we do the first anastomosis, that is the duodenal ileal anastomosis. So we need to check that anastomosis is on the right size, that the food will be passing through without any complication. But we need to make sure that it will be tight enough that we close all the anastomosis. So normally the anastomosis is done on 2 or 3 different layers so we can fully close everything. And then we do a leak test, that is a blue dye leak test, and then we do the methylene blue and plus the hydropneumatic leak test. So we have water and air leak test, and then we have color leak test. And then we need to check that the blood supply will be proper, so all the tissues will hold together. And then we do the other anastomosis, and we check that the blood supply of both of the anastomosis is good. So both of the surgeries, either the duodenal switch or the CDS surgery, they're very complex surgery. Every time that the surgery is done, we need to be very careful and take the full time. So it's a longer surgery, but it's a safer surgery because we can take the experience and the time, so we can do a proper dissection and we can do the proper anastomosis without putting you at higher risk.